Lasers are devices that rely upon the stimulated emission of radiation to produce a single coherent wavelength within the ultraviolet, visible, or infrared portion of the electromagnetic spectrum. Whereas high-power lasers are used in laser medicine to cut or destroy tissue, physiotherapists use low-power lasers to relieve pain and stimulate or enhance cell function through phototherapy, or so the theory goes. Briefly, low-level laser therapy is theorized to work on the basis of the first law in photochemistry, the Grotius-Draper law, which states that light must be absorbed by a chemical substance in order for a photochemical reaction to take place. The generally accepted theory is that low-level laser therapy can impact chemical reactions like oxidative phosphorylation and therefore the production of ATP, or chemical substances like the respiratory enzyme cytochrome C oxidase, which is involved in the electron transport chain in mitochondria, for therapeutic benefit. Research is ongoing about these therapeutic mechanisms, but its effects appear to be limited to a specified set of wavelengths and parameters. In this lecture, we will review the basic principles of low-level laser therapy, how it is produced, applied, and its evidence for treating a number of different musculoskeletal conditions. Lasers are devices that rely upon the stimulated emission of radiation to produce a beam of light. The word laser is an acronym for light amplification by stimulated emission of radiation. Lasers are comprised of an energy source, a resonant chamber, and an active medium. Let's start with the resonant chamber, which contains the active laser medium and several reflective mirrors. When they are in an unexcited state, the electrons of the atoms in the active medium orbit their nucleus at their lowest energy level, or ground state, and these orbits are closer to the nucleus. But when an external energy source is applied to the resonant chamber, this excites the electrons in the active medium and moves them to a higher orbit. As the electrons return from the excited state back to the ground state, they spontaneously emit photons of energy in the form of electromagnetic radiation. These photons reflect back and forth between the mirrors of the resonant chamber, some of which reflect all of the photons, and others which reflect only some of them, and then they ultimately exit the device, where they are directed to a target tissue. These target tissues contain chromophores, or biomolecules, which are capable of being excited by the incoming photons. The way lasers are produced means that they have some unique properties when compared to other forms of electromagnetic radiation, and these include monochromaticity, coherence, and collimation. Monochromatic means that all the photons in a laser beam are of the same wavelength. Coherence refers to the synchronization of a laser beam in time and space, where the photons of the beam are in phase and coherent. By comparison, the photons in conventional light travel randomly. Collimation means that the elements of the laser beam are nearly parallel because there is little divergence. Laser beams can be focused to a small area. Again, this property differs from conventional light, which diverges substantially. When laser energy strikes the tissue surface, that energy can be absorbed, reflected, transmitted elsewhere, or scattered. The kind of interaction that happens depends upon a number of variables, including the active medium, which determines the wavelength of the laser, the power density of the laser, its pulse duration, the spot size used, the fluence or energy density of the laser, the properties of the target tissue, and the duration of tissue exposure. The wavelength of the laser beam determines the degree of tissue penetration, the amount of energy that is absorbed, and the amount that is scattered. Basically, longer wavelengths penetrate more deeply. The pulse duration, also known as the pulse frequency or pulse rate, is determined from the thermal relaxation time of the target chromophore. The thermal relaxation time is the time needed for the tissue temperature to return to its baseline temperature after heating. For example, if a tissue is heated for a period less than or equal to its thermal relaxation time, the accumulated heat is confined to the target object, whereas if a target is heated for longer than its thermal relaxation time, conduction leads to heating of surrounding structures. The spot size is the diameter of the beam emitted from the laser as it strikes the tissue surface. Energy entering the target tissue is attenuated more rapidly with a small spot size compared with a larger spot size, because scattering is greater with a small spot size. The spot size is usually determined by the equipment you are using. For example, the spot sizes of the equipment we will be using in our practical classes ranges from 0.13 to 0.28 centimeters squared. Next, the amount of energy that is delivered. Energy is measured in joules, and fluence, or energy density, is energy divided by the application area, so its units are in joules per square centimetre. When it comes to medical lasers, the destruction of large tissues or structures requires high fluence due to the amount of tissue that needs to be heated to achieve thermal coagulation. But for low-level laser therapy, the fluence is generally below 35 joules per square centimetre. Power describes the rate of energy delivery and is measured in joules per second, or watts. Power density, the power transmitted per unit area of cross-section of a laser beam, which is measured in watts per square centimetre, is inversely proportional to the square of the diameter of the spot size. In other words, energy applied over a small surface area means higher power densities compared with the same amount of energy applied over a larger surface area. Lower power density produces slow heating that coagulates tissue, while high power density heats tissue quickly and can vaporize tissue. So there are the various parameters, but how is low-level laser therapy actually applied? Well, a lot comes down to the type of machine that you have. For example, I had mentioned before how the wavelength of the laser, and therefore the depth of penetration, is determined by the active laser medium of the machine. So for this parameter, the machines that we have here are capable of producing lasers with wavelengths of between 600 and 1000 nanometers, which is associated with the depth of penetration below the level of the dermis into the underlying subcutaneous tissue. Their spot sizes range from 0.1 to 0.3 centimeters squared, and their power outputs are between 65 and 200 milliwatts. So really, the only parameters we're going to have any control over are the pulse rate and the treatment time. When calculating the desired energy density, the World Association of Laser Therapy have guidelines for a variety of different conditions. So for instance, they recommend delivery of an energy density of 8 joules per centimetre squared for treating Achilles tendinopathy. As I said before, energy density is the energy divided by the spot size, and energy is equal to power multiplied by time. So we have the target energy density, 8 joules per square centimetre, we have the power of the machine, let's say it's 0.2 watts, and we have the spot size, which is 0.25 centimetres squared. So the last remaining unknown, treatment time, is the energy density multiplied by the spot size divided by the power, or 8 multiplied by 0.125 divided by 0.2, which gives us a 5-second treatment time for the area we are treating. The last parameter, the pulse duration, can be controlled on the machine. Generally, for more acute and superficial injuries, low pulse rates are used, while higher pulse rates are preferred for chronic conditions. Taking this example of Achilles tendinopathy, which would be considered a chronic condition, a pulse duration of 5 kHz might be used. Treatment might be performed daily for 2 weeks or every other day for 3 to 4 weeks. Contraindications, according to the North American Association for Laser Therapy, are presented on screen. But does laser actually work? What's the evidence? Like other electrophysical modalities, the evidence for the effectiveness of laser is conflicting, of variable quality, and depends on the population being studied. The World Association of Laser Therapy, or WALT, recently published recommendations for the design and conduct of clinical studies of low-level laser therapy, but currently available evidence rarely follows all of these recommendations. You see, performing research on electrophysical modalities is complicated because patients' expectations probably have an important role in the benefit that comes from a treatment, so the placebo effect is often at play. That's why high-quality, randomized control trials where the patients and therapists are blinded to group allocation are so important in this field, but they are rare. Convincing evidence for the efficacy of low-level laser therapy in patients with tendinopathy is lacking. A systematic review and meta-analysis of controlled clinical trials reported inconsistent results, with 12 studies showing some benefit, while 13 reported inconclusive results or no effect. The authors noted that, like much of the research investigating other electrophysical modalities, studies varied in quality and in the doses or parameters used. A 2005 systematic review of studies of low-level laser therapy for patients with lateral epicondyle tendinopathy concluded that there was no clinically significant effect either in the short or long term compared with placebo, and several controlled trials in which patients were randomly assigned to treatment with low-level laser therapy or placebo laser reported that active laser treatment did not improve outcomes beyond those achieved with eccentric exercise. For patients with low back pain, results again are largely inconsistent. For example, 4 trials found laser therapy to be superior to sham therapy for pain relief and improvement in function up to 1 year following treatment. However, 2 other trials failed to show a benefit of laser therapy when used either alone or with exercise. Findings from a 2008 Cochrane review found that the evidence was inconclusive for the use of low-level laser therapy in the treatment of non-specific low back pain, with the authors noting that protocols varied widely with lots of different treatment doses, durations, and wavelengths used, and these findings were echoed in 2 other systematic reviews published in 2010 and 2015. And there's lots of other research which has been done in other patient populations. I can't go into too much detail because it would take too long, but I'll give you a brief summary of some of the better systematic reviews. One review concluded that low-level laser therapy may be useful in the treatment of both acute and chronic neck pain, but then another more recent review, with meta-analysis, concluded that the benefits were insignificant and that the evidence had a high risk of bias, which is just another way of saying the available studies were low in quality. A Cochrane review published in 2005 found that low-level laser therapy may be useful for short-term pain relief in patients with rheumatoid arthritis, but again, the studies that were included were deemed to be at a high risk of bias. For osteoarthritis, another Cochrane review found results to be conflicting, making it difficult to draw any conclusions. And another Cochrane review published in 2014, investigating a range of electrotherapeutic modalities for frozen shoulder, found that there might be some benefit for laser, but this was based on one low-quality trial. And I could go on, but the findings are largely the same, inconsistent and conflicting, with lots of low-quality, heterogeneous studies, but new evidence may emerge to change this. So that concludes this lecture on low-level laser therapy. To recap, I started by outlining what lasers are and how low-level laser therapy is used as an electrotherapeutic modality. I outlined the theory of how it might work and the various treatment parameters. I finished by discussing some of the research investigating its clinical effectiveness.